Welcome. Thank you all so much for joining our HBS HAA webinar today. We are so grateful to have our panelists here today and our board member, Patty Carolla, who is going to introduce our speakers for our topic today. Thank you. There. It took me a minute to get to my screen that I needed. Thank you all so much for your patience. Again, welcome to HBS HAA's virtual roundtable for the day, Thursday, July 9th. We have a variety of things going on this month as well. We have 2 more webinars, so please check our website to see if there are others that you would like to register for or and other things in the future. We have all of our information there. Today, we are coming to you via Zoom, so you can use the Q&A section to ask questions, and we will get to as many as we can. At the end of the webinar, you will have a survey that pops up. This is the correct URL, so don't be afraid to click on it, and we would be grateful if you would complete that for us. I am now going to turn it over to Patty Carolla and thank her so much for doing our introductions for Angela Okuma and Neil Sample. And we are really looking forward to today.
Excellent, thank you, Susan. So we're thrilled to have Angela and Neil here with us today to talk about innovative approaches in healthcare, leveraging technology and data to positively impact patient outcomes and experiences. So I'm Patty Carolla. I'm one of 20 board members on the HBS HAA. And our goal is to help all of you and bring topics of interest to you. And we encourage you to bring topics of interest to us and participate in these virtual roundtables. They've really taken off as a result of COVID. And so we're very happy to be here with you today. I'm very grateful to Angela and Neil. Let me first introduce Angela. Angela is EVP and Chief Digital Officer for Novant Health. She and her team deliver world-class consumer capabilities, differentiating technologies, and advanced clinical solutions that allow her organization to provide remarkable patient care. The stories are incredible that I've heard from Angela. Angela also served previously as EVP and CIO at Rent-A-Center. She was Global CIO at BVP International, Global CTO at AstraZeneca, and Divisional CIO at Dell. She also held technology executive leadership roles at Bank of America, SunTrust, UPS, and my very own IBM. Angela has a master in computer science from the University of Tennessee and holds 3 US patents. So please join me in welcoming Angela. It's my pleasure also to introduce Neil Sample, EVP and Chief Information Officer at Northwest Mutual. Neil's key areas of responsibility include technology strategy, data and analytics, and the Northwestern Mutual Data Science Institute. Prior to joining Northwestern Mutual, Neil was Executive Vice President and Chief Operating Officer at Express Scripts. He also previously served in executive roles at American Express, eBay, and Yahoo. Neil received his MS and PhD in computer science from Stanford University. He doesn't have a Stanford mug today, though, as you'll see, he has a Star Trek mug. So, so please join me in welcoming Neil. So let's start off with our first question. You know, Angela and Neil have such varied industry experiences, and these experiences helped shape, you know, some of the innovative approaches that they're using at Novant Health. And those that Neil used at Express Scripts. So maybe Angela, if we could start with you, would you please share your thoughts based on your varied experiences at Novant Health, Bank of America, SunTrust, UPS, and IBM? You know, how has that led you to some of your innovative work at Novant Health?
Thanks, Patty. So one of the mistakes that I think people make when they move from one industry to the next is they try to just lift and shift solutions that may have worked in one circumstance into another. When in fact the value that I think we bring when we move around between industries and we learn, it's not to increase the number of tools in our toolkit that we can then deploy to, you know, what looks like the same problem to us in another company, but rather it's in the ability to learn, the muscle memory that we develop around looking at very complex industries, oftentimes under some sort of transformation in an industry, and understanding, how to tease out what the opportunities are, how to recognize things that are maybe artificial constraints versus things that are real opportunities. And of course, how do we best bring the company into an industry leader position. And it's not the same playbook to be run every time. And by the way, healthcare is evolving rapidly. As our healthcare industry continues to evolve, it's not reasonable to expect that the same sorts of things that work well today are the same sorts of things that will work well in 5 years. 5 years from now, we're probably not going to make money the same way we make money today. We're probably not going to engage our patients the same way we've historically engaged our patients. We won't offer the same set of services that we offer today. And I say we, not as Novant Health, but we as, regardless of the sort of the institution for which you work. So these are the sorts of changes that I think drive a sense of urgency around bringing diversity of thought, diversity of experiences into your senior leadership team. Because 20 years of experience in healthcare, this time 5 years from now, may be less interesting as a leadership capability than perhaps a diversity of experiences might be. I'll pass it over to Neil and see what he has to say. And I hope the leaf blower outside my window isn't too distracting.
No, it's fine. Neil?
Yeah, thank you, Angela. Similarly, I think I would agree that you have to bring your other experiences, but apply them in novel ways in healthcare. So one of the things that I found sort of startlingly different coming from American Express, a sort of brand and services oriented company, into healthcare was the notion of end-to-end responsibility for service and outcomes. And so one of the things that was fantastic about American Express was there were never any excuses for the customer or client. That if somebody called in and they had a merchant issue, American Express would say, fantastic, thanks for noting this to us. We will give you a credit and then we'll go off and pursue the issue with the merchant on your behalf. There was an end-to-end responsibility. And what was interesting was that service model never showed up in healthcare in the same way, because unless you're in an integrated system like a Kaiser in California, for example, it's fragmented, that there are different payers, different providers, specialist networks that aren't part of hospital groups, and nobody necessarily feels responsibility for it. When we talk about the service levels in healthcare, oftentimes you hear phrases like bedside manner, which indicate that it's probably about the physician, but how often you hear a critique of the typical waiting room experience, right? That's not something we focus on, whereas American Express would have said end to end. American Express, the NPS, the Net Promoter Score for somebody who came in and had a billing dispute, it actually went up because, American Express sort of had your back. That was the brand promise, and people actually got some value out of the experience. How many times do you think people go into billing disputes in healthcare and feel better for the process, right? It's intractable, it's different. And so, I would say one thing that was a stark contrast was that notion of end-to-end servicing in healthcare. It was not the same thing, except in very specific circumstances. The other thing I would say that I would bring to healthcare from other areas, and I think Angela would concur, this is sort of universal, is that whatever vertical you work in, whether it's healthcare or financial services, et cetera, consumer expectations are set differently. They're actually set by consumer electronics. They're set by companies like Apple and Amazon, and those become the standards by which you're judged. It doesn't matter that those happen to be in retail and consumer electronics. That's going to set the expectation for healthcare. That's going to set the expectation for financial services. That's going to set the expectation for various industries. And so that's something that I think we have to be aware of, that, measuring ourselves, for example, against our peers is not enough for consumers, that we have to measure against their expectations, even if they come out of industry. So I think there's been a tremendous amount of learning in other industries that we can apply to healthcare. But we have to realize that we're going to be judged by a yardstick that's maybe not of our own creation.
Thank you. Yeah, wonderful thoughts here. You know, you can't lift and shift. This muscle memory you mentioned, Angela, and the ability to learn and diversity of thought are just key for you know, when you transition from one industry, one role to another. And then this end-to-end responsibility that you bring up, Neil, and the Amazon and Apple example of they set the bar for consumer experience. Those are such critical thoughts that we have to think about. So let's talk about the incredible success that you've had in marrying technology with healthcare and leveraging data to positively impact the patient outcomes. So can you please share some of your best practice approaches? Angela, do you want to start? I know you have some great stories.
Oh, thank you. So happy to share that. One of the things that that I think historically healthcare systems have struggled with is the tendency to host one's clinical data inside of an environment that is the EHR platform. And one of the first things we were able to do a couple of years ago inside of Nippon Health is we were able to liberate that data and make it available to our advanced computing teams, cognitive computing, the AI, the people doing AI-based algorithms, the people who are doing a lot of our advanced analytics work, a variety of third parties who are able to help us do some machine operations with that data. And in this sort of data lake environment that we have that has robust API layer associated with it now and all the rest of it, we were now able to tease out a lot of interesting value, a lot of interesting things. So, for example, our goal, one of our lofty goals, is to be able to predict major health events before they happen for our patient population. And we get closer to this goal when we start to consider, behavioral data that may be commercially available about our patients, when we start to consider, health and wellness data that our patients willingly enter into, our data environment, as well as the clinical information that we have, as well as, environmental related data elements and things that many other industries are already taking into consideration when they try to find best ways to engage their consumer base. So we are also using those same mechanisms, but with a clinical slant. So, for example, we are able to using some of our homegrown capabilities and some of our co-created capabilities, we're able to do a pretty good job preventing readmissions around cardiac patients. We're doing We've had 3 different iterations of suicide prevention modules that get us to about a 90% accuracy rate. We estimate we have saved many hundreds of lives with that capability. We have the ability, and by the way, as it relates to preventing major health events, sometimes it is just predicting major health events. So, we're working with a partner now to look at elevated biometrics to determine when the body is triggering an sort of an inflammatory response to, perhaps a virus, the presence of a virus. So, before a body starts exhibiting any sort of overt symptoms, now, particularly, it's interesting to have a sort of a notion of whether or not someone who's asymptomatic may be trying to fight something off. So these are the sorts of things that that are certainly technically possible today. It's just not necessarily historically been something that's part of the portfolio of activities that a health system does. And it's all enabled by, I think, using best practice to manage data. And we do a lot of work with streaming data and have a variety of partnerships that are interesting in the stroke care space. Taking data that's streaming out of a CT scanner and applying an algorithm that is developed by a third party to it that allows us to determine before the scan is complete whether or not there's an operable occlusion, which allows us to pull a stroke patient out of the CT scanner and put them directly into the OR. Treating them sometimes in as little as 14 minutes with an operation to remove a brain bleed from the time they show up to the emergency department to the time it's gone. So we're sending stroke patients home with no symptoms more often than not. And by the way, that's the sort of capability that allows us to address health inequities, because that same capability could be is being made available in our community hospitals, not just our big flagship, stroke center hospitals. We have, partnerships underway that will allow us, this next describing is not in production, but we're working with a university that allows us, that has an algorithm developed to analyze mammography images and help determine with a fairly impressive degree of accuracy the likelihood of a patient developing breast cancer, in the next 4 to 5 years. So you can think about how that would change follow-up behavior for the patient as well as for the patient's care team if we had some indicator of that risk. So a lot of what we do is all about throwing up flags saying this patient's at risk for that and so on. Using the same set of capabilities, not necessarily in the clinical space, we've also been able to apply, intelligent algorithms to a variety of, and I use that term very loosely. I have to have that disclaimer because I know Neil's listening in. He will correct me. But we use these learning algorithms in some of our scheduling solutions that we put into place. So we just built a huge cancer center, just a huge cancer center. And guess what? There is no physical waiting room in that cancer center. We went all in. We placed our bets and said, you know what? We can manage patients coming in and out, and we don't want any of these immune-compromised patients to be sitting in a waiting room. So we have the solutions in place that allow us to, move them in and out of infusion chairs without having to sit in a waiting room for a period of time before that. We've used the same sort of technology that we had developed for the cancer center and moved into a bunch of other, many of our other facilities, of which there are about 700, a little over 700 at this point, to keep our patients from having to go in a waiting room now at this time where we're worried about, again, things that are perhaps contagious. We have used the same, a derivative of the same sort of technology to help with scheduling, automatic scheduling of our ORs. So now that we've opened up all of our ORs for elective surgeries again, we need to fill those ORs. And we've been able to fill them with greater rapidity and with the most efficiency through applying the same sort of scheduling algorithms that, have come a long way since the CS 101 sorts of scheduling solutions that you had to write. So it's all been very gratifying. I think, the patients, the quality of care, we've seen a lot of positive progress. The access to care, we continue to see tremendous progress. And it's just been an extremely exciting time to be in healthcare.
Excellent. Thank you, Angela. Neil, over to you.
Yeah, I might add a short anecdote. So I think, on the pharmacy side, it's a little bit different. Sometimes pharmacy is the tip of the spear. It is the literally the prescription for what ails you. Sometimes it's part of follow-up care. And Angela talked about cardiac readmissions, right? And one of the factors there, for example, is drug adherence, right? Are people going to take their drugs as prescribed? Are they going to take the full regimen? Are they going to take it on time with food as prescribed, et cetera? And so from a pharmacy perspective, that's one of the biggest problems we have. And I'll fudge the numbers a little bit, but this is directionally right. You're going to find about 60% of your patients are going to do exactly what they're told. They're rule followers, they're diligent, they're invested in their outcome, and they are going to take their full regimen, and their aftercare will be, likely pretty good. You've got about 10% of folks who aren't, and there's almost nothing you can do. There's no intervention. They're bulletproof, they're invulnerable, they're young, and they're feeling better, and I don't feel like I need this follow-up, whether it's a narcotic or an antibiotic or whatever. They're just not gonna follow the suggested course of care. The 30% in the middle, though, the ones that are at risk of non-adherence, that could be a dramatic difference, right? The difference between 10% non-adherence and 40% non-adherence is a big deal, both financially and ultimately clinically from an outcomes perspective. So one of the things we found at Express Scripts was that not just focusing on clinical outcomes, but the behavioral economics of aftercare and adherence was pretty powerful. And I found this example to be kind of compelling from our own data research, where we applied data science to the notion of adherence. And so we ran a model. We had a fairly rich and robust model. Sometimes we had complete medical records and labs and a lot of data. Other times we had holes in the model. But there were up to 425 attributes that were put into this model. And we would get a score that basically said how likely someone was to be adherent or not. And what we found was that the machine learning did much better than anyone could ever possibly predict. That the ability to collapse and collate all of that data was pretty remarkable. And it would indicate what kind of intervention we should do. Would someone respond well to a text? Or are they in a critical position? Do they need a pharmacist outreach, which if you're operating a business, might get you to the right clinical outcome, but you can't deploy it everywhere without discretion because ultimately it's too expensive to do a sort of a call to everybody. Or it might be as subtle for a diabetes patient to have a laser print on the top of their bottle, their metformin that says, "Have you checked your A1Cs lately?" Right? It could be that simple. Well, the thing that came out of the model that was really eye-opening, the largest single factor for the prediction of non-adherence was if you had a patient who was a male over 40 who also had a female primary care physician. Right? That was the #1 factor. It accounted for about 70 basis points of non-adherence. So male patient over 40 who had a female primary care physician, a prescribing physician. And it turns out that for us was sort of a big red flag, that those things taken together were something the machine spit out that proved that it was a high likelihood of non-adherence. Now, if you cut the data in different ways, if you said, oh, is there a difference between male and female, you'd find out that it's not actually significant in terms of predictability. Or if you said over 40 and under 40, again, not discretionary enough. Or primary care physician, if you took their gender and if you even thought it was interesting, turns out if you said, well, male versus female, nope, no real difference in non-adherence. But when you mixed those three factors together simultaneously, the machine could figure out that this was likely to be a problem. And this was something that you couldn't figure out on your own. Now, we weren't in the business of explaining why. Who knows why it happens to be that men over 40 apparently don't listen to their physicians as often or as closely and follow the instructions when their primary care physician is in fact a woman. But knowing it means that you can make that intervention. Having the machine figure it out, you don't even need to know what the root cause is, but you can say, this is a red flag. This is a problem for adherence. And if you're trying to prevent cardiac readmission or you're trying to make sure people take their dose of medication, that's what's important, is identifying the cause or the factors that look like they're going to lead to non-adherence. You don't even need to fix the factor. You just know that you're going to do your intervention. You're going to reach out and you're going to get to better medical outcomes. That was the kind of thing we couldn't really do 10 years ago, 20 years ago. It's interesting in that it doesn't require the underlying cause to figure it out. You don't need to know the social determinants of healthcare. You're literally looking at what feel like some basic demographic factors independent of the condition. And all of a sudden, you know when you've got a patient who's a higher risk of non-adherence. So amazingly powerful stuff that just was not fathomable, 20 years ago. And you probably never would figure out with humans that the machine learning models are the ones that are figuring out these insights. And then for a sociologist or a psychologist, you might get the insight and say, well, that's obvious. I can tell you what's going on here. but without the machine learning and the big data, you were never going to figure it out.
Great. Thanks for sharing that story, Neil. And, and in combination with what the stories you shared, Angela, around liberating the EHR data and making it available to so many parties and allow such collaboration to predict and prevent major events that have this incredible impact on outcomes and costs. Really innovative ideas. Thank you for sharing, both of you. So healthcare is really a tale of two cities, legacy and new. Can you comment on how you effectively digitally transform an organization and take that legacy and new, take both legacy and new into account? Angela, maybe we'll start with you.
Thanks. I think there's actually, I was just looking through the Q&A list, and there's somebody's asked a question that I think is relevant to this. Someone mentioned that he or she had was working, their care team included physicians from a couple of different healthcare systems, and they were expressed some frustration that perhaps the records were not being shared between the systems. And that sort of constraint is a legacy constraint. So there is either a technical or a process reason the way those two systems, one or perhaps both of those systems engage, that is keeping that from happening. There are, in our case, going back to Neil's description of the end-to-end, patient journey and the different touch points that a patient might have with a healthcare system. We pay very close attention to that. We understand that the care team might not always be made up of, as much as we'd like it to be, Novant Health team members and clinicians. So, in our case, everything is digitized. Our modernization was largely, I think some of the foundational modernization activities that we had to go through were very much like those that you'd see in other industries. So, rationalization of the tech portfolio, different methodologies for prioritizing work, different ways in which we structure teams, ways in which we think about the competencies that our teams need to have, and the ways in which we deploy those competencies to different product sets, and how we think about product and how it aligns to capabilities. All of these things are activities that are happening in every industry, right? We're all trying to figure this out. Well, actually, we're all applying it, one hopes, no longer trying to figure it out. Once that piece is done, then, it really is a matter of leveraging those sort of modern ways of thinking about engagement and doing what we can once we've eliminated the barriers associated with the technologies that we have in place, doing what we can to make sure that the right interoperability is in place. So today, in our case, at Novant Health, if you wanted to share your record with another physician, it would be you'd open up the app, your My Novant app, and it'd be a couple of clicks, and off you'd go. You would, if you wanted to come see one of our folks and you want to physically see us, you could come in and be auto-checked in. You don't have to talk to anyone. You'll go straight in. We'll even do an SMS. You want to hang out in your car, we'll tell you when your room is ready, and you come. When you want to see your test results, you'll get it the same time your primary care physician gets it. It'll be available to you on the portal, patient portal, which is, again, part of the app. You can have a virtual visit on demand anytime. You can schedule a visit. You can schedule a visit online or using your app with a specialist if you want a specialty consult online. It's all the things that we as consumers would expect from any entity with whom we engage. And Neil's other comment was great. We're not just competing with other healthcare systems. We're competing with Apple. We're competing with Amazon. I say that is the greatest thing to happen to healthcare, because a different way of looking at that is that our patients are already trained in how to engage with us using this mechanism. Our physicians and our advanced practitioners are already trained in how to engage using these sorts of tool sets. So digital engagement is no longer awkward for most people. Our research shows that 94%, this is old research, a couple of years ago, so it's probably horribly low. But at the time, the research was that 94% of American households have access to a smartphone. So that means 94% of U.S. citizens or American households are, in fact, pretty proficient in using this device to engage in a variety of activities across all of their, every aspect of their lives. So, having these virtual visits, of course, in great demand during the stay-at-home phase of the COVID response, it just was a very natural thing. It so happened, related to digital health, by the way, that we had already anticipated that would be, we were skating to where the puck is going. So we had a robust capability in the digital health space that includes not just, as I mentioned, on-demand video visits, scheduled video visits, and so on, but we also have partnerships with device companies. So we can take vitals from our patients when the patients are in their homes. We can look down their throats. We can look in their ears. We can look at their nose and the eyes. We can listen to their lungs. Obviously take the temperature, his heartbeat, and all the rest of it. So we do that live, and we can store that information into their medical record. So we can store that right there immediately. And we can do that asynchronously or while the patient's talking to one of our practitioners. So during the COVID crisis, we had about somewhere between 10 and 15,000 virtual visits a day. Not a problem. The only sort of ramp up that we had when we started promoting, when we closed our clinics down for a couple of months, is I think we had to deploy some webcams to a handful of people. And we had to train 2,000 physicians who hadn't yet gone through the training that we'd already developed. So it was just a matter of, quickly spending, a day and a half training 2,000 very smart people who made their way through med school and had no problem understanding how to use the tools. So it's an example of modernization, preparing a company, regardless of the industry, for many possible futures. Legacy systems, legacy processes will always constrain you, will always prevent you from being able to respond to the unexpected. So I would think of modernization activity not as a nice to have, but as something that should show up as like number one on your risk register. If you haven't modernized processes, tools, the way in which you think about tech and data, you're going to have competitive threats that you can't even imagine right now.
Mm-hmm. Neil, thank you, Angela.
Yeah, so Angela did a great job, I think, covering the new side of digital, and I think that there is a tremendous amount of opportunity to operate differently than we have. I'll maybe focus on the less interesting side, on the legacy side, a little bit more, and to kind of complete the answer. I think there are a couple of challenges that keep healthcare from feeling modern and being modern, if you will, end to end, right? Especially when it comes to the hospital system, for example, that's installed an EMR, that the switching cost would be, 10, 20, $30 million. If it's not even a large hospital system, the idea that they're flush with cash is, people talk about the expense of healthcare, but it's not like these are high margin businesses. If you look at the payer side and you look at the health plans, it turns out they are in an open market and are competing, whether they're going direct to consumer or they're an employer-sponsored plan. Turns out they have to compete on price. That's their primary factor, which means there's not a lot left over to go off on a tech journey, to do modernization, to clean up all of the sins of the past. So the first myth about healthcare is that while maybe it feels expensive from a consumer perspective, that there are just these rivers of capital flowing that can allow you to update the legacy. So I think in general, that means healthcare tends to live with legacy a little longer. So it's great that we can modernize, we can achieve a lot more, but there's baggage, there's technical debt, if you will, that makes it difficult, that makes it complicated. And there's just not the free capital to sort of change everything because it's Thursday. Let's install Epic instead of Cerner, because that leads me to my second thing is the switching cost is incredibly high. And I don't just mean financially. So in healthcare, we have a natural conservatism because the switching costs can be high because the impact to the patient, the clinical outcome can't be impaired. And so when you take a system that knows a particular way of inputting data, managing client records, doing otherwise simple things, sending out scripts and referrals, the risk aversion is in the change process. It's really about what is going to happen if we miss some data, if the new system isn't as perfect, if we don't understand how it works, and it takes up too much time and the administrative overhead goes up. And so there is a conservatism around change that I think is well-deserved in healthcare. It was interesting when I was back at say, Yahoo or American Express, in the technology department, they might literally say, well, that didn't work, but nobody died, right? Like that was like, it wasn't that big a deal. It was just software. On the other hand, if you ran a process like drug utilization review, that's going to happen in real time as somebody's pricking up a script from a retail pharmacy, and you've got to paw through their entire prescription history to make sure that you don't see something contraindicated or that there's going to be a negative reaction. Turns out if you get that wrong, people will die. That is a consequence. And so there is a conservatism, an anti-pattern for change that happens in healthcare that isn't present everywhere else, right? If you go to financial services, they're trying to tweak the other end. They're trying to be as fast as possible, making decisions as quickly as possible so they can do timing captures of alpha in a market that's moving, right? It's a very different incentive structure, very different set of motivations. So I think a couple of reasons why I'd say we live with more legacy than we would like comes down to that sort of lack of access of free cash flow, that we can't just go in and change things. And then secondarily, even if we wanted to and had the means, there is a very high risk of change in healthcare that's not present in other industries that, again, means we have a little more legacy, we have a little more tech debt than we would really like.
Mm-hmm. Yeah, thank you, Neil, for pointing out the challenges, free cash flow, and, healthcare organizations are living with more baggage. And Angela, you mentioned the move to virtual care and doing 10 to 15,000 visits per day during the height of the crisis. I attended the Fortune Brainstorm Health session over the past 2 days, and the CEO of the Mayo Clinic said prior to COVID, they did 200 telemedicine visits per day. And during the height of COVID, they did 35,000 visits per day. I myself had 3 virtual visits, and they were great. My doctor loved them, and so did I. So this is fascinating what has happened to virtual care. And the last question before we go to the Q&A is, can you both comment on the patient-physician experience and how the current healthcare crisis has impacted that experience? Angela, would you like to start?
Sure. So, one of the questions, I was just looking at the questions, somebody asked, why do physicians complain about the health record? And that has, when we've historically, before the crisis, when we think about physician experience, the sorts of things that we end up typically talking about are, does the physician have access to enough information about the patient before, the patient is seen? And that, is one of the functions of the electronic health record. And what happens while the patient and the physician are together, which is, also involves the electronic health record and the keyboard that sits between the physician and the record, and oftentimes the physician and the patient. And then, of course, subsequent to the visit, the physician's lengthy experience typing notes in. And so, post-visit, because they're not going to do all of that while the patient's there. So, so there are a few things. Of course, with the COVID crisis, we've now seen a lot of that. We've seen more digital visits, more virtual visits. So that's just a digital channel by which the same visit is conducted, not a physical channel. So I think we've talked a little bit about that. But as we talk about physician experience, I'd like to talk a little bit about some of the advances that are potential for us. I mean, obviously, everyone on this call understands the importance of having electronic health records, right? We need to understand, we want to understand the patient's journey, the patient's health journey, the things that were asked, the things that were answered, the thoughts that the physician or the advanced practitioner has had during that visit, the orders that are issued as a result of the visit, the tests that are ordered, et cetera, the follow-ups. All of that needs to be carefully tracked. And we've also talked about what happens to that data, right? We've talked about ways in which we can learn all sorts of interesting things from that data, either about that patient in particular or about the, in aggregate set of patients. What we haven't talked about is the clumsiness, the clunkiness of having a physician, have to type something in. There are technologies, and we're piloting one early iteration of this technology, but it's all voice-based natural language processing, so that as a physician and a patient are together in a room or in a space, virtual or otherwise, the notes are taken, that the conversation is being analyzed, and appropriate data elements are being automatically populated into the record. So that replaces the keyboard. Right now, we're doing it just with our orthopedic physicians. It's a very narrow use case. Natural language processing is a a little bit easier when it's, when you can train for just a narrow space. And so that we're seeing how that goes, but I know there are a lot of really interesting, there's a lot of great work happening in that space across, from a variety of companies. So I look forward to seeing how that's going to evolve in the next handful of years, assuming we can afford, as Neil mentioned, to implement it. Before the patient walks in, how many of you, I think this is sort of a question that's rhetorical. When's the last time you think your physician read, when you walk in for a visit, read more than the last note? So there's notes associated with each visit that you have. Do you think the physician read the last 2 notes, the last 3 notes? How about 10 years of notes? Has the physician gone back 10 years and read all those notes before you walk in? Probably not. Can't say for sure. But of course, again, that's just crunching data, right? What information could we potentially tease out of 10 years worth of notes or 20 years worth of notes, and ways in which things have evolved for you as a patient, and could we potentially elevate certain areas that should potentially be, a question areas that a physician could potentially say, hey, I recall, 6 years ago, this, that, the other happened. Has anything occurred? Have you had any subsequent, whatever risk areas we can identify as a result of crunching that data, we should be able to present that to the physician, and the physician can choose to ask the patient about this if it seems like it might be something, So these are sort of simple things we can do that we're working on to try to make that experience more seamless. And of course, similarly, if we can use natural language processing to allow, right now, our physicians can dictate their notes, right? They don't have to type it in. But if we could have those thoughts captured and largely populated as a result of something that's listening in on the actual visit, that would be ideal for physician resiliency and the like. Neil?
Yeah, so I think Angela did a great job summarizing what is different, and it has been different. This is, again, we hear unprecedented, which I think we translate to mean, well, every 100 years this happens, but most of us haven't been around 100 years yet, so it feels different. What I would say is different, and I'm hopeful and actually optimistic, is that this is one of those watershed moments where there's a willingness to change that hasn't been present before. And, a few of us might be over 40 potentially. And if you are, when you were younger, online banking was not a thing. It just, the internet was a sort of a Wild West place we didn't work on. We certainly would never put our personal information on there, et cetera. And I ended up in a strange consulting agreement where I worked with Wells Fargo to put online banking in Wells Fargo branches, right? And so the idea for them was, people didn't need to be coming to tellers and to the bank to do all of their financial transactions, and yet they wanted to. It made them comfortable. So Wells Fargo's strategy was to let their customers get referred to in the bank to an online kiosk that's 15 feet away and develop their comfort level. And now, we wouldn't hesitate to check our balances even on our cell phones. And so there was this shift that said banking and financial services should never be done on the internet because it's a dangerous place. And now it's sort of commonplace. And so this, I think, could be a shift. The thing I would say is that technology seems to be accelerating the willingness to change, right? That's the one thing that I think is true, and it's a little cliched, but because it's true. When I think back to, one of these dramatic examples, it was, you think about the lessons I got when I was a kid. Don't share your information with strangers. Don't tell people things over the phone. Don't get into the car with strangers, right? Like these are good pieces of advice. Check your Halloween candy, right? Throw that in there also. And so now there's an entire business around exactly that, an entire industry and a sector. So if you think about Uber, what are you doing? You're giving some stranger your personal information over the internet so that you can go and get in the car with that stranger, and he or she's just as likely to have a piece of candy or a mint in there that you're going to feel comfortable taking. And so all of these things that were by themselves, sort of dangerous, bad behaviors have been remixed together simultaneously into something that consumers like and feel pretty good about. And so the watershed, the thing that we may get from COVID, for example, is a willingness not only on the consumer side, on the patient side, but on the physician practices as well, that there are a lot of folks who were reticent to participate in telemedicine, that it wasn't how they were introduced to the practice of medicine. There were folks who even said, look, I can't be as effective. Maybe this is a violation of the Hippocratic Oath if I try to operate this way, a real reticence. But what we've got now is that catalyst. We've got that spark. We've got that moment in time where things are so different that we're willing to do things differently. And then technology is there to enable that difference. So I think it's powerful. It would have happened eventually. And I think the current crisis sort of accelerated that transition.
Mm-hmm. Yeah, thank you. It's interesting when you talk about those experiences, having this virtual experience. One of the questions in the chat is, how do you make it more personal? And I'm reflecting on my own physician experiences that are face-to-face. And Angela, you talked about taking notes and the question about people complaining, the doctors complaining, I have to take notes. It takes you away. They're at the computer and you're sitting on the exam table. And I have one physician that I've gone to for a number of years, and he remembers everything. He rarely writes things down. And so I was there, and he's in his 80s, and I think he's about to retire. And then during my last visit, he said to me, this is Elizabeth, and she is going to take notes, because the hospital said, if I don't take notes, I can't do this anymore. And this is what I love to do, to talk to you, to engage. And it's personal. I feel that with my primary care and specialists, I've had great doctors. So how do we make it personal? Having that CRM, where your physician really knows and makes it a welcoming experience virtually. Is there anything we can do to help? This is a question in the chat.
I think Neil's answer, his story about Wells Fargo, I think was very applicable here. It's about comfort level. If I'm uncomfortable in whatever circumstance I'm in, I'm going to be thinking about that discomfort, right? I'm not going to be hanging on a physician, which you definitely don't want me to. I don't want me to do that. But if I'm a physician, and I'm talking to you over face to face, and I'm uncomfortable for some reason, whatever, then I'm probably not paying attention to little clues and little, things that you may be visible to me, but I'm just not paying attention because my comfort level's not there. My mind is not freed up to notice those things that maybe my subconscious would normally pick up on, because my subconscious is worried about my level of discomfort, right? Mm-hmm. So, that apple's a little enlarged, and, being able to ask you, hey, what's going on with your throat, and maybe determining, hey, we need to get that, let's get an ultrasound on it or whatever. Things are weird, so I might not notice that if I'm worried about, oh gosh, I can't really see Patty well, and can she hear me, and and so I think, like in the Wells Fargo online banking example, getting people like your physician you just mentioned comfortable with leveraging new methods and feeling and creating, again, with the muscle memory, but creating that muscle memory so they don't have to actively think about the weirdness of the engagement, I think it's going to go a long way. This crisis, I heaven help us. I mean, it's been a disaster, right, for the society. However, it has taught us how to do things slightly differently, and we are now looking at a society where people are trained to engage this way, and we can't lose this opportunity. I feel very comfortable. Of course, we've always used this sort of mechanism, but I feel very comfortable. I feel like I'm in a room with Neil and Patty right now. This is, I'm not thinking about, oh gosh, this is weird, we're on a screen. I feel like we're chatting up on stage in a panel scenario. It's easy. And I think that degree of comfort and familiarity is what's going to make a change for us.
Mm-hmm. Neil, I don't know if there's some questions here that you'd like to answer. I loved your comments about the spark. This was a spark for a lot of interesting things that are happening.
Yeah.
Yeah, go ahead.
Yeah, I might, it's interesting. I might add, going all the way back Patty, to your first question around what can we learn from other industries, and if we look at Julian's question around the experience, making it more personal, I do think that's a critical lesson we can learn from other industries. And so, I would say look at the industries who are focused primarily on making it more personal, right? On managing a connection. Those who are financially incentivized, for example, to connect your wants and desires, right? And it can be a little crass at times, but I would recommend we look at advertising, right? At marketers. And those are folks who do a very good job matching desire to product. And they do so in a way that depends on kind of understanding the customer, somebody who maybe they haven't even met before. And it can spill over into creepy and annoying, right? Like if you go to any website, go to Toyota.com, for example, it's a potential high value transaction. Watch what happens everywhere else you are on the web. It doesn't matter if you're on a news portal or you're on Facebook, all of a sudden you'll start getting ads for Toyota. And if you looked at a specific vehicle, you will in fact get ads for those specific vehicles. And they'll put a color palette chooser in front of you, right? It does get a little overbearing at times, but at the end of the day, it's remarkably effective, that they do a good job personalizing. They go to what you would think of as kind of the economic sweet spot for personalization. It may feel overbearing to us, but that's because their yield management algorithms tell them that, you know what, if you go too far a certain percentage of the time, you'll have that many incremental sales. Like they are brutally efficient at personalization. And so I do think there's an opportunity to take a look at some of these adjacent industries and say, what is it that they know? What is it that we should put together in terms of a patient profile to make it more effectively personal? To Angela's point earlier about the 10 years of case notes, maybe case note summarization, pulling out the high points and looking at the trends over time would be an effective thing to do, right? Now, there are regulatory hurdles. It turns out if you, in an automated way, summarize the notes without a physician or something, there's a lot of risk if you miss something, right? And so there are hurdles that keep us from operating like advertisers. But again, I think if we start to look at where they have been effective, we can start to find hints. We can start to find techniques. We can start to find some tactics that will help us achieve better outcomes. Certainly, part of the patient experience, feeling connected, is we're not always best at that outside that primary care relationship, right?
Mm-hmm. Yeah. Thank you, Neil, for that. There's another question in here around innovation and whether it occurs more as part of small experiments or whether there are larger, more collaborative initiatives across multiple systems that are driving more innovation. Not sure what your thoughts are on that, either of you.
Yeah, we have, I think I would like to believe that most entities, regardless of industry type, have figured out that not all good ideas come from within the four walls of that entity. And so therefore have found ways to create an ecosystem that is part of their collaboration network. And in the case of Novant Health, we have a service called Experimentation as a Service that we use. We actually allow, we have 30,000 team members, and many of them are highly innovative folks and have great ideas. And using this mechanism, which lives in part of our Institute of Innovation and Artificial Intelligence, we're able to quickly pull appropriate subject matter experts into a room, a virtual room. We're able to, we have constructs that are contractual that allow us to engage with a variety of third-party types, whether it's a research group or university typically, or a startup, or another healthcare system in some cases, and we work on a problem together with a solution that may or may not be optimal. We find out, and the idea is that the purpose of the experiment is, as one would hope, to learn, and just because our hypothesis was proven to be not true doesn't mean that it was a failure as an experiment. So we don't use those terms like fast fail and all the rest of it. We fast learn, and that's that I think is oftentimes in collaboration with a variety of third-party entities, not necessarily just within the four walls.
Mm-hmm. Yeah, Neil, I welcome your thoughts on that.
Boy, I agree with Angela, and I guess I'll fill in with the glass half empty side of it again. In terms of healthcare, we have a couple of things that are challenging, uniquely to our industry. I think, again, first and foremost, collaboration can be difficult because data sharing can be difficult. Even where a consumer or a patient would want their data shared, we know how hard it is to get EHRs showing up from specialists. The number of times that you show up in a waiting room the first time you're in a practice and fill out the same forms, the same things that ask about your age, your weight, your allergies, etc., medical history, it's nearly 100%. And it doesn't matter. You can go from a physician's office to an ophthalmologist and then to a dentist, and they're going to ask you the same set of questions that really haven't been changed. And so it's kind of amazing. It's really, really hard for the patients. And then when systems try to collaborate to share data, it makes it difficult. It makes collaboration in healthcare difficult because of the questions around whether it's HIPAA or privacy, PII, et cetera. The other thing I would say is, and again, this is a little more unique to the pharmacy side, is that oftentimes the financial outcomes prevent collaboration. So I've seen it not only from Express Scripts as a pharmacy benefit manager, but I also sit on the board of the St. Louis College of Pharmacy Board of Trustees. And I'll tell you what, when you've got a researcher, for example, looking at something in the pharmacogenomics space, potentially identifying a blockbuster drug, these are the things that are remarkably profitable. And they're sort of big bangs, right? It's like buying lottery tickets. Most of the time you fail, and then sometimes you win, and sometimes you win very big. There's a perverse incentive to prevent you from collaborating in the same way that you might with a network entity in a different business, right? So, think about a network model like Visa. And it turns out Visa wants to be everywhere. They're sort of a utility player, and they don't care who the issuing banks are, as long as they meet a particular standard. And so you've got maybe Citibank and Chase competing with each other, but they're all working with Visa to make sure that anywhere you show up in the world, in the US, et cetera, that the Visa card works. And so they're not in competition with themselves. And so I do think that's true to a greater extent on the pharmacy side than the medical side. But that gets in the way on top of already having a fairly difficult environment to openly share patient data.
Mm-hmm. Alex Gorski, who's the J&J CEO, spoke yesterday at this conference, and he said he's never seen such collaboration and partnership and sharing of data, and how we're working together to accelerate finding a vaccine. And he hopes it continues. So it's, again, this catalyst, this forcing function is making this happen. There's the Department of Energy and IBM have this high performance computing consortium. And it's everybody that competes with one another in industry, along with government and academia, just racing to find this cure. So I'm hopeful that some of these partnerships will continue post-COVID. So 2 minutes left. We have one quick question that I want to get to from Robert DeNoble here. How do you think quickly hospitals will respond to this financial crisis? More consolidation? Other thoughts? Angela?
Well, for the reasons that Neil mentioned earlier, a lot of hospital systems pre-COVID were already doing a lot of consolidation to outrun their losses. And so, there's no reason to believe that you're going to see that stop. We at Novant Health have, been more thoughtful. We were very fortunate with a very strong financial position, and so we had the luxury of being able to be very thoughtful about our growth plans. Although we've traditionally been a high growth system, we have been very intentional about the cultures and how we allow our system to evolve and so on. So but there is no question that the COVID crisis has created a very significant hit. As Neil mentioned earlier, this is private sector. right? These are companies that have to earn money that they spend to keep the lights on, right? This is not as if, by and large, systems are not, are not taxpayer funded. Now we do have many of us have tax status that's nonprofit, but part of that agreement is that we provide, hundreds of millions of dollars of care to the communities we serve free of charge. And so we do that. We track that. We know how big that number is. It's massive. And so on a yearly basis. So yeah, it's going to be interesting to see if that accelerates some of the struggles that we've seen in the smaller hospitals, community hospitals, rural hospitals. We see closing. We saw closing before COVID. I think it's reasonable to expect that this could be a real problem for some of those entities. We'll see.
Thanks, Angela. Neil, the last thoughts?
Wow, I don't know that there's any sort of magical recipe here. I do think that we have highlighted some real challenges. So for example, noting the difference between the aggregate capacity of systems, especially hospitals, and then the local capacity of systems, probably wasn't shown more dramatically than maybe in New York City and the crisis as it evolved there. The challenge, though, is I don't know what the answer is. We thought we had maybe a little bit of a solution on the commercial property side, like WeWork, right? All of a sudden you had, didn't matter, you need to spin up an office and you need 50 seats and you've got a startup or whatever, you want to be in New York City, fantastic. Here it is. It's sort of like Uber for real estate. I don't know what the equivalent is, the WeWork or the Uber of ICU. Right. And so I do think we've demonstrated some real difficulties, that capacity being stranded or localized is a bit of a challenge. Right. And it's highlighted issues. Right. So rural hospitals and the financial struggles that they've faced, it's made maybe more dramatic and we start to see some of those challenges. But I wish I knew what the actual answer was. Do I think we'll have some more consolidation? Yes. I think it'll probably be driven out of necessity more than strategy. That if you were on the cusp, for example, if you were on the edge before and you get this little bit of push financially in a negative direction, it might just be over. I think some of us were really surprised just a week ago when EMSI on July 3rd announced we are ceasing operations on July 3rd, right? And so as an insurer, as an underwriter, we use them for paramedical exams, data gathering, et cetera, and they were just gone. And to me, that's a little scarier in the healthcare space than it would be in retail. If a big box retailer says, hey, listen, we don't have the volume, we're not gonna make it, it's like, lamentable, but there are substitutable, there are alternatives. If we see and start to see large players in the healthcare space have to fold because of the dynamics that are going on here, I have a significantly greater concern. So how will it evolve? I don't know. Will it evolve? I think absolutely. And hopefully we'll be left with a more resilient system, one that's got a little more elasticity, that's a little more dynamic. And then, of course, on a more secure financial footing, that would be great too. But I think at this point, it'd be too early to call. I don't know how we're going to break left or break right. I just know there will be changes, and the optimist in me, I'm hopeful that they won't be too disruptive, that we'll be able to absorb them progressively.
Great, thank you. And thanks for the question, Bob. All right, we're at the end of our time. I thank you. I feel like Angela said, I feel like I've been in the room with both of you. And Susan, of course, thanks for helping get us all together. So for all of you on the line, thanks for joining. These are recorded, so Susan will be sending out the recording soon. And we look forward to our next virtual roundtable. We're doing this again actually next week. And we have a great, on Thursday next week, we have 2 great executive coaches joining us. And I'm really excited about that as well. This was terrific. Thank you again, Angela and Neil. And thank you all. Look forward to the next one. Take care.
Thanks, Patty.
Thank you all so much and hope to see you soon. Have a great weekend.
You too. Bye.